Hi, everybody, and welcome back to the Bridge podcast where medicine meets the arts. I'm Julia, and I am the facilitator for our 9-week program. It's a 9-week narrative medicine course called The Bridge, where each week we explore a different facet of what it means to listen, read, and live more attentively. Last week, we talked about patient-centered approaches and what it means to close read and how close reading informs a close listening practice so that we can really hear and engage with patient stories. This week, we're looking at the what we're going to call the third space or the intersubjective space, where between a listener and a storyteller, meaning is co-created. A lot of times when I start talking with physicians or care providers about what narrative medicine is and what close reading is, a lot of the feedback I get is, well, yeah, sure, I know how to listen to patient stories, but they don't come in just to tell me their stories. They actually want to know my wisdom too. They're coming to me for help. So this is where we start to really explore the dynamic of listening and also sharing our stories as well, and the space between where meaning is co-created between a patient and a provider. Um, so this week we look at a painting by Frida Kahlo called The Wounded Deer. And when I ask students, to sit with Frida Kahlo's painting, I'm really asking what part of this painting belongs to Kahlo and what part of this painting belongs to you as the viewer. And we've explored this question in a lot of different ways this week through close reading and reflective writing exercises. And that's really the real question is what belongs to the both of you together? And that's the heart of narrative medicine, I think. The intersubjective space where meaning is co-created between the text and between the reader, or between patient and provider, or in our case, between multiple readers of the same text, how we triangulate meaning together. Today, I'm joined by Justin Westbrook. He is a clinical psychologist from Portland, Oregon. I am so glad that he signed up for this particular podcast, not only because his insights are radical and mind-blowing, and I've loved watching his posts on the discussion board, and they've really changed a lot of the ways that I've viewed these materials, but also because as a clinical psychologist, he brings very a unique insight into this, what we're calling third space or intersubjective space. So I'm really pumped for this conversation. Um, so welcome, Justin. How you doing?
Doing all right, Julia. How are you?
Really good, really good. Thank you for being here.
Good.
I thought maybe we could just get started with you letting us in on who you are and what you do.
Small questions. Let's see. Yeah, so I was born and raised in Pennsylvania, did undergrad in Michigan, grad school in California, and been up here in Oregon since 2012. Um, uh, my wife and I have a 2.5-year-old son, and so a lot of my we talk about how it's kind of Groundhog's Day. We get up and do the same sorts of things over and over again every day, which in some ways is nicely structured, and in some ways looking forward to when we can do a bit more differently and more spontaneously in the future again. Um, let's see. Yeah, so I'm a clinical psychologist. I work integrated in a primary care office. I've been here at this clinic for over 7 years now, and really just uh, I love the team approach. So we've got our doctors and medical assistants and nurses. We have a dietitian. We have a social worker. We have um, uh, uh, triage nurses and care management nurse, and a clinical pharmacist, and it's also a training clinic, so we have medical residents here. I get to train a couple of student therapists. And so it's just great to have all, speaking of kind of the third space, have all of these different providers with their areas of expertise, their approach, what they bring to the picture of the patient, what they hear from the patient, which might differ from what others hear, or what also honestly what the patient is willing to share with different providers, either based on, what their area is or what their relationship is. Often we find certain patients, I'm their touch point, or the PCP is more their touch point, or the pharmacist is the one that they really connect with for whatever reason. And so that can be a really helpful balance there too. I used to work in community mental health, which I enjoyed in a lot of ways. But it really was hard. Like we would try to connect with primary care doctors and things like that, but we'd call, they'd be in an appointment, they'd call us back, we'd be in an appointment. And here you walk down the hall, you stick your head in their office and like, hey, can we talk about so and so that we can
That's
kind
awesome.
of work together? Yeah. So
Yeah,
that's a bit about me.
that's really fascinating. So it's not just about triangulating meeting between patient and provider. It's also about the way you get to coordinate meeting with this whole team of
Mhm.
providers.
Yeah.
That I'd love to just sit with that for a second. So what happens when you do have a touch point person? Does that touch point person become the primary person that patient is interacting with? And how
Mm.
does communication go with the whole team about things that might be shared that are relevant to their plan?
Yeah. Um, so often if someone connects more with one person, that probably is the person they're seeing or contacting the most, although it kind of depends on what their issues are and who's the one that can provide the most direct assistance for that, of course. Um, but yeah, we have uh, team meetings. We with the electronic health records now. We all have access, and we let patients know up front. We're all charting in the same place. We're all able to see those things, so that we're all on the same page as best we can. We can have those kind of drive-by. Oh, hey, can we step into your office and talk about this person, or set a time to do that? We're able to um, you know, do some secure chat kind of stuff within the electronic health record. So it's really helpful in that way. And yeah, with the third space, so you're getting the patient story, you're getting the patient's story as heard and interpreted by this person, and then as heard and interpreted by that person, as well as now we're talking about this patient and what of that story secondhand that we're not discussing, right, comes out in the midst of that. And it's a really great team here. There's a lot of consistency over time with the people that are here, which also helps with building our relationships amongst ourselves as well as with the patients over time. So,
So cool. I wish
yeah.
more healthcare operated this way. I feel like a lot of what my experience of healthcare is very siloed, in
Hmm.
specialty, and there's not a lot of collaboration or communication across the silos. And it sounds like you guys have really, found a way around that problem. I love it. So what drew you to narrative medicine in general?
Mm-hmm.
What are you picking up from this study that's useful for you in your practice?
Yeah. So um, I came across narrative medicine when I was Um, so where I work, I get a certain amount of money for continuing education every year, and if you don't use it by the end of the fiscal year, you can roll over half of it, but if you have more than half left over, um, it's forfeit. And so these last few years, especially with COVID, so wasn't traveling a lot, and then now having a toddler, I'm not going to a ton of conferences or things like that at this point. I often have a bit of that left over toward the year, so I am often looking ahead at, well, what am I going to need in the coming year? Are there some trainings that I could sign up for in the coming months or something? And one of the things that psychologists, at least in Oregon, are required each licensure cycle, which is every 2 years here, is I believe it's 1 hour of chronic pain management training as part of our CE. And so I was looking on PESI for, is there something there maybe that I could get for the next year? And I ran across your um, presentation, which I think was part of a broader
Great.
online conference. But they were marketing just yours as one option too, on narrative medicine related to chronic pain. And so um, I I love stories. I love like my family is a storytelling family. Um, we love to sit around and tell our stories. We love TV shows and movies. We talk about those, comic books, novels, et cetera, et cetera. And so when I was in grad school and kind of looking at what kind of therapy do I kind of want to focus on and maybe kind of make my base while still pulling from other things as needed to help patients, I was really drawn to narrative therapy,
Mhm.
and kind of learned a bunch about that, incorporate that into my practice. And so when I saw narrative medicine related to chronic pain, that was a no-brainer to me. And so really enjoyed that presentation and the approach, which is what we're doing more of over time in this, and I found the class, and it just resonates with me and the work that I do. Um, yeah, and it's great to keep getting more practice with these approaches, and it really tickles my kind of engaging with texts of various kinds on various levels. Kind of an online book group. We're not doing books per se, but as well as, you know, um, the applications to my clinical work itself.
Great, great. Well, you are
Yeah.
such a joy to have in this class. And I often, anytime I get folks like you who already have such a facility with stories
Mm.
and who are such natural storytellers and who work with stories in their day-to-day life as clinical psychologists or other kinds of providers, I often get a little nervous, like, oh, what do I have to teach them? And then I
Oh,
remember that this is not about teaching at all. That really what we're doing is just playing together. We're exploring text together. And I'm glad that you are getting that feeling of fun from this, because that's what I want this to be, as a place for people who do often have to listen to other people's stories on a daily basis, to give them a chance to actually sit and play with their own for a little while and to write and to dive into their own musings. Even when we're talking about each other's thoughts, there's still a creative process that goes on in the close readings that should feel nurturing and should feel good. So I'm glad you're enjoying that.
yeah.
It is really fun to get to exchange with you on the discussion boards.
Mhm.
So let's talk a little bit about what we've been doing this week with Frida Kahlo's Wounded Deer. So, first of all, not to put you too much on the spot, but can you describe this painting for folks who might be listening?
Mm-hmm. Sure. So it's kind of a painting in a wooded area. Um, The central image is a picture of a deer. It has Frida Kahlo's head, face, ears, as well as deer ears, antlers, and such. This deer has been pierced by 9 arrows, is actively bleeding.
Mm,
There are trees on both sides of her. There is a broken limb on the ground that has what look like fairly fresh leaves. And in the background, there's kind of a clear path to the background, where there is some sort of body of water as well as some storm clouds, some lightning.
mhm.
Um, yeah.
Great. Great. And then, since we're talking about this third space or intersubjective space, do you mind sharing anything about how your own personal or professional experiences inform or shape or color the details that really stand out to you here? How does your lens shape how you are noticing these details?
Mm-hmm. So, when I clicked on the link to open the picture initially, I had a jolt when I do it. I don't.
Yeah.
I am aware. I was aware of Kahlo, and I'd seen some of her work before. I don't know if I've seen this one previously. I didn't remember it if I did, but it had a visceral reaction. And actually, as you just asked that question, I was thinking part of why that might be, and I think part of it is, I got into the field that I'm in for a variety of reasons, but one of them is I knew early on in life I can't do blood, and so like physical health kind of things is not for me, and that's okay. I remember dissections in biology class, and my partner would do the cutting, and I would do all the paperwork, and that's how we kind of divided things up. Um, so I think maybe um, part of it is the boldness of the damage done to the deer, very external, very clear, um, as well as that, prototypical Kahlo face of you can read into it a lot of things. Is it Is it serenity? Is it surrender? His acceptance? Is it um, not challenging you per se, but like, you know, hey, pay attention. There's a lot in that face, I think. And I was thinking how in my line of work, I'm definitely confronted by suffering and pain in a variety of ways, day in and day out. Um, but I work with folks who so often their pain is invisible, which is true of lots of physical pain for that matter too, right? So I think seeing this deer with all of these wounds very clearly external, right? Which potentially is Kahlo externalizing her invisible chronic pain issues that we're not always um, able to see. So I think that maybe is part of my initial reaction is what kind of pain do I work with versus I'm not in the emergency department. I'm not pulling the arrows out and suturing those wounds and things like that. Um, yeah.
Yeah. Yeah, this brings up a lot of great ideas for me. Pain as invisibility, or I'm sorry, chronic pain as invisible pain often um, invites art into it, to express it, whether that's a patient just trying to describe it through poetic
Yeah.
terms. You kind of you there's no way to show somebody else your pain unless you illustrate it in some way. If that pain is not, visible in an embodied way. So, as a part of our exercise was to look up a little bit about who Frida Kahlo is and how her lived experiences may have informed this particular painting. And as you pointed out, she lived with chronic pain, which may have, at least up into a certain point in her life, might not have been as visible to others. But that also brings up something that came up a lot on the boards, that visceral reaction that you had, the revulsion of looking at this, all of these wounds on a body. Um, for some people, it turns this experience into a spectacle. At what point are we just, you know, looking at wounds and using them for our own kind of creative benefit, and at what point are we actually being with the painting and being curious about it, and leaving space for those wounds to speak. Like there was something happening on the boards this week as far as this idea of a spectacle is concerned, and the ethics of turning pain into spectacle. I don't know, do you have any thoughts on any of this? It's kind of
Um,
a formed thought that's not fair to volley over to you.
yeah, no, that's totally fine. It made me think of when I was talking about kind of the informed consent we do here at the clinic of we're a team, we share medical information with each other, so we're on the same page. I make sure to state it in that way. And sometimes I've actually added this additional piece of we're not just sitting around talking about you and your stories.
Mm.
Um, right? We're not gossiping. We're not, we're talking about medical stuff here, right? So, uh, because I've seen that pull at times, and if I'm being honest, I'm sure I've seen it in myself at times too, be like, oh my gosh, let me tell you about this, or the spectacle, or what have you, right? But how do we humanize? Um, right. The point of sharing the information is to provide additional information, adding to the whole of our understanding of the person, so that we can then approach them holistically, help them holistically as best we can. Um, and so, I wonder if, um, adding her face could be a variety of reasons why she does that, of course, but kind of humanizes the deer in a way. Although it was interesting on the boards to have this back and forth with some about how, in some ways, connecting with the animal or the animal side of things or something is has a different feel or way of connecting as well as the human side too. And I think someone even covered up her face when looking at it for a bit and seeing the different reactions that they had to the painting at that point. So, um, I mean, I partly the ethics of it, I think, is Kahlo is herself choosing to present herself in this way and sharing it this way, and knowing that it's I, I guess I'm making assumptions. I don't know enough about art. I assume knowing that others would be seeing this, and I think I saw it was a wedding present, which was wild to me. What a present! On, but I mean, it's a Kahlo painting, so there's that. Um, so what is someone choosing to show us? Um, and how are we then receiving and treating that trust,
Mm,
that sacred space and story of putting it out there, that vulnerability? Um, and in some ways, call out in the painting itself, what I know, which I won't claim as a ton, seemed pretty confident in a lot of ways. Maybe not in all areas of her life or such. We're all a mix of things, but she did a lot of self-portraits and things like that. And so, but still, there's a vulnerability to that, even if you are doing it regularly. And I think about how often people with pain have to tell their story and put it out there over and over again to people they are just meeting.
right.
Can I trust them? Do I? I don't know, but I've got to in some way, right? Um, please, please treat me well. Please be gentle. Um, yeah.
Beautiful response. Thank you so much. I have another ethical question for you that
Hmm.
I've been thinking about when it comes to this intersubjective space. This, on one hand, this third space between patient and provider, or between readers, or between text and the reader, this place where we're kind of co-creating meaning. On one hand, it's a place where we can identify with other people. We can see shared ground and we learn to lean in to another person's perspective. But on the flip side of that, I think it's also a place where we recognize that we bring our own baggage to the conversation. We bring our own
Mm.
personal lived experiences that color the way that we view something. In other words, we bring bias to the conversation. And that's not something that we can ever get rid of because it's kind of built in, we all have dirty lenses. And I'm just curious how you handle that as a clinical psychologist, what do you do to stay aware of your biases?
Mm.
And how do you handle them in a therapy encounter?
Yeah. Well, let's break that down into a couple minute answer. Let's see. Um,
So unfair of me today. I
so part of it, it's an ongoing process, which hopefully is true for us humans in general, regardless of what we do to earn money. But um, and that involves self-reflection, that involves interacting with other people who are not my patients, because that's not their job to help me figure that out. Of encountering people and ideas. And again, I love stories. I was the one reading novels and stuff during grad school, and everyone would be like, "We read enough. Why?" I love it. So part of it is getting to experience other people's worlds that way, and coming into contact with my own approach and how is that the same or different or things like that. Um, Part of it is ongoing consultation and making sure that, again, that team-based approach here is helpful. And I'm actually not the only psychologist here. The need has been so great that we've added on another one in the past year. And so it's been helpful to have people to bounce things off of in that way. Um, so part of it is, right, we worldview bias, perspective, lens. Um, right, our strengths are our weaknesses, our strengths are our weaknesses, right? There's something, I mean, maybe bias isn't the one I want to say is good, but there's a helpfulness to a lot of that stuff because, which is good because we can't not bring that with us, right? I know some in my field talk about leaving parts of yourself at the door, and typically it's religion, spirituality kind of stuff. And absolutely, we're not here to proselytize. We're not here to put our views, beliefs, perspectives on other people, whether that's religious or otherwise. Um, but I think it's disingenuous and even dangerous to suggest that we can leave parts of ourselves at the door. That's how we're going to get bias, harmful effects of bias and things in there, right? And so obviously we need to be on the lookout for those harmful stereotypes and holding things loosely as we're working to understand the patient and what is true for this individual in front of me versus, um, you know, stereotypes or what research on large groups has suggested is a trend or right. Um, how do we bring all those pieces together and hear the patient? And what are we bringing? Because sometimes, like you said at the outset, they're coming to us um, to share their story, but they're sharing their story in the hopes of receiving some sort of support, help, whatever it might be in return. And our stories are involved in that. Our story has involved whatever training that we've had, whatever perspective we're able to bring. Um, and and in my field in particular, and I think this is true in helping fields in general, but um, we talk about, or no, we talk, the research has shown the connection, the relationship that one has with their therapist far and away accounts for the most outcome effects for the therapy. So if you have a terrible relationship with your therapist, they can have all the techniques in the world, they can be the expert in this type of therapy, etc. I'm not saying nothing positive can happen out of that, but it's going to be very limited, right? And so we encourage people to shop around, so to speak. Who is a good fit? And part of that is it might be what worldview, baggage, bias, whatever. Again, there is a negative side of that, and I don't want to um, deny that. We need to keep, okay, where are the spots on the lenses that I need to keep rubbing, or just be aware it's there so that I can like hold it in. Where do I need to get my own therapy as well? Um,
Yeah.
sometimes, right? To make sure that I'm in the best space that I can be so that I can be there for others.
Beautiful reply. So, following up on that idea of the between space of your relationship, I want to hear about the reflective exercise for you, not necessarily the content of what you wrote, but what it was like to write from both your experiences and from the imagined experiences of the painter. What was it like to try to kind of meld both of those voices together into something creative?
Mm-hmm. Yeah. Um, it's interesting since we're given that 5 minute
Hmm.
constraint, which I think is really interesting, helpful, frustrating, all the it's also really helpful with a busy schedule. Like, okay, this is going to take me 5 minutes, and I I know when I can fit that in. Um, but I think someone also shared on the boards like how much they love it. It's like a every time you click on it to see what the prompt is, it's a surprise, and now we're off and going, and what are right. So for me at least, can't speak for others, but it's not a lot of me sitting and planning what I'm gonna. It's like I don't have time for that, right? Which maybe is part of the idea of giving a fairly short time limit. In some ways, I've been surprised at how much time it is when you're in it, but also it's only 5 minutes. Um, so I kind of just kind of try and let it flow. I'm
Hmm.
not saying I never delete something after I've written it and like, yeah, no, that's not quite right, or where did that thought come from? That's not maybe true to what I'm experiencing or whatever. And so it's kind of a letting the writing come through me into my fingers, and I don't know where it's gonna go, right? This one that I wrote was more um it wasn't really poetic. I guess there were poetic aspects to it, more prosy. The one before it you know, um, was not. The one before that, the introduce yourself, right, had a lot of, well, you could go a lot of directions with it, but it was, the structure is what's your name? And that's the story with that. So in some ways, I was like, okay, well, I go through my names. Um, so in this case, I can't really, I think I pictured or had up the painting again, um, and kind of started with Kahlo, what I imagined maybe she might say. And I think it was a combination of the painting, what I was getting from her, what I was reading others kind of experiences and interpretations of the painting were, as well as kind of my own experiences in therapy. And I work with people with chronic pain with behavioral cognitive kind of techniques and stuff too. And it's not just with chronic pain, but I've been in sessions, especially often first sessions, where it's like, um, um, they need to, it's clear that I'm being tested might be a bit too strong a word, but maybe not. Like they need to know, like, are you with me? Are you going to hear me? I don't I don't have time to waste. If
Yeah.
this is not going to work, fine, moving on. But like we need to know up front. And so I think that's where some of my was coming from, coming out of that, and then what have been my experiences with that? How have I responded? How do I hope I respond? I'm sure it has not always gone the same way. Um, yeah, so it was kind of a flow, but I think it was a flow of all those things somehow coming out in 5 minutes in that format.
Yeah.
Yeah.
Great. Yeah, and I too love and am frustrated by and all of the feelings about the true experiment of the 5 minute writing
Yeah.
prompts. In fact, in a weird way, I find even if a thought is incomplete or I never even got to the thought I was trying to get to in the first place when I started writing,
Mhm,
it always
mhm,
somehow ends up winding up exactly where it should have. Like it ends at the perfect little moment.
yeah.
Um, and I think it's because it circumvents our rehearsals. And
Mhm,
I've often thought about this as a useful tool for, self therapy, journaling, how to
mm,
get past your rutted narratives of whatever it is you think you are, who you think you are and how you engage with the world. You have to figure it out really fast when you're just writing it down, and the different directions your brain goes than it normally
mm,
goes in these rehearsed ways
mhm,
can be really very interesting. And you said that, it didn't take much effort, you weren't really even thinking about trying to meld the voices. It just kind of happened.
mm, mhm,
And
mhm,
in this particular example, the exercise was to, kind of try to imagine the space between voices. But I noticed that in almost every reflective writing activity that I've ever done with folks, this writing in the shadow of the text happens naturally. Like
mm,
you don't even have to ask people to, in light of what we've just discussed, or in light of everything we've learned about that, right now, write about this. It just happens naturally. You hear echoes of, images that we've seen in the original text, or little
yeah,
snippets of conversations that have developed on the discussion boards just naturally kind of eke their way in.
mm,
So there's a cross-pollination that happens that I think is really effective too in helping us get out of those rutted narratives by brushing our own stories up against the stories of others. So yeah, I love that you're having that experience too.
yeah. I
Um,
like having the balance too of like there's the one, the first assignment where there isn't a time limit, you can dig in, you can
right.
edit, you can think about it, right? And then there's the quicker, let's see where we go with this kind of thing. And both kind of feel vulnerable to share
Mhm.
sometimes, but I feel like that 5 minute one is more so for me at least. Like, all right, this is what I wrote, and I'm gonna follow the rules and not go back and edit anything. Hopefully, nothing too terrible came down here, or how is this gonna strike others, right? This is my just kind of free flow, not edited, not trying to, be as careful as in the other one or whatever. And I wonder if there's something there in terms of meeting with patients too, how much editing, how much is blurted out, how much, both are vulnerable in their own way. But yeah.
About vulnerability. So
Mhm.
this is the last unfair question I have to
Oh, then we
throw.
get to the fair questions.
No,
All
then
right.
I'm done because all my
Oh,
questions
okay.
are unfair. question. And if you have no thoughts on this, that's fine too. But I'm
All
just
right.
very curious to hear from a psychologist's perspective about scope of practice,
Hmm.
because that's a question that comes up a lot for folks in narrative medicine. A lot of times, at least in my classes, I a lot of my work focuses on pain care, as I'm sure everybody notices from the introductory videos. So I'm working a lot with manual therapists and
Hmm.
physical therapists, occupational therapists, massage therapists, yoga therapists, people who work with folks in pain. Oftentimes we get folks in the in different kind modes of therapy in as well. But as I'm teaching them how to listen and engage with patient stories, one big kind of challenge that I get a lot is, wait a minute, that's outside of our scope of practice. We don't do stories, we
Hmm.
do bodies. And, I always
Interesting.
gently push back that, bodies are stories, and we have, we have to have, we have to be able to engage with both. But the flip side of that is always when to refer out. When do we know, okay,
Mm.
this
Mhm.
is something that is really beyond me and needs to be, held by somebody else with this training. What is that point for you, you think? When would you suggest that a manual therapist refer to somebody like yourself?
Interesting. Yeah. Um, so my mind initially went to kind of how do we even construct what is mental health and mental illness, which um, maybe is not where you were going with this at all, but that's where my head went. And we've actually moved or working toward moving as a field of kind of not that this is a binary thing, that there are some of us who have mental health and there are some of us who have mental illness, but that there's a continuum there and that we all fall somewhere along the continuum and we move around it throughout our lives, right? Um, and so when we think about, well, how do we determine, what is a mental health condition? And let's be clear, there's research involved in that, but there's also plenty of politics involved in that. But we look at things like how frequently are these issues happening for you? What is the intensity of them? What's the duration of them? Um, how, in terms of the population, is this common or is this rare, statistically speaking, right? Those sorts of things. So, what I would say is that, um, when you're talking with folks, I mean, most of the time that I find they're going to start with a story anyway, right? I mean, some people are more just the facts, ma'am, and kind of have their bullet points and things like that. Um, but we need to engage with that story in some way, and different professions, I'm sure, have different approaches and things like that. But um, if we get that connection with folks, they're more likely to engage with us to follow through on the things we want to encourage them to do and things like that too. So I'd say that um, we what is it called? Person-centered therapy. Carl Rogers is a big person in the field of psychology, clinical psychology, and I mean, there's a lot to his stuff, but basically it comes down to three things: genuineness, being true to who you are in the encounter.
Mhm.
That doesn't mean you overshare or put all things out there, but like be genuine, be empathetic, right? Not get caught up in people's emotions or drawn in or whatever, but being able to meet people in their emotions while creating enough of a distance that you are able to remain yourself and be present with them and continue to engage and help them in the ways you can. And then demonstrate respect, or what's sometimes called, um, yep, totally blanking on it, of course, um, unconditional positive regard,
Mm.
which, let's be clear, none of us are capable of doing at all times with all people, but any of those for that matter. Um, Now, there's a whole system of therapy built around Rogers' ideas, person-centered therapy and such. And I'm not saying you need to be trained in that or you should be doing that if that's outside your um, wheelhouse, your areas of competence. But I think all of us can work and practice on those three things, and we can all work to improve over our lifetimes on those three things. Um, and within therapy, there are some who would argue Roger's approach is necessary and sufficient for change, that
Mm.
you're creating this fertile ground with these sorts of things, and there's different techniques that you use within that to create the space for people feel safe to learn and grow themselves, and they can do that. And for some folks dealing with some issues, I think that's true. I've found it to be true. But for some folks, it's necessary, but not sufficient. They need perhaps further insight or need to learn some new te techniques or ways of taking action that they don't know how to do. And so we need to build off of that, right? Um, but if you don't have that foundational stuff, going back to the, you know, patient therapist relationship, probably not going to get super far anyway. So I'd say part of it is that, part of it is, um, you know, you can provide those sorts of things if people need things beyond that, perhaps, right? Or how much functional impairment, another way we look at mental distress and functional impairment, how much is being caused there that seems to be coming from some sort of emotional, cognitive, behavioral kind of thing that's not related, or is connected to what's going on, but maybe not related to what your specialty is. Obviously, if there's anything to the extreme of suicidal thoughts or psychosis or things like that, I mean, those ones probably stand out pretty prominently to folks, probably don't need to remind them of that. Um, um, yeah, I will say one caution I will give that I have seen sometimes, thankfully not a ton, but I'm sure it's more widespread. Um, just because someone comes and cries in an appointment sometimes does not mean they have a mental health condition. Doesn't mean they can't stand to or not stand to benefit from talking to someone, even perhaps a therapist, right? We don't have to go to therapy just because we have a diagnosis or something. We can all benefit from having someone to talk through things with. But um, I have found sometimes, especially when it's a middle-aged woman
Mm.
who comes in and cries and has a good reason for crying, right? This isn't just like, oh my gosh, my emotions are totally out of control. I don't know what's going on. But like, no, we're talking about something hard and I'm crying because of, as I'm talking. I have sometimes gotten referrals for that. And they will show up and they will tell, and it's often a male provider who has made the referral, kind of revealing their discomfort, I think, more than anything. And like, I don't want to deal with this. Um, and so often they'll tell me what happens, like, oh, well, is there anything I can help you with? Like, I'm so sorry, that's ridiculous. Like, I try not to throw people under the bus, but also like, that's not okay. Um, um, is there anything that would be helpful for us to talk about? I mean, you made the time, you showed up today, is there something we could make use of the time for? If so, great. If not, have a nice rest of your day. You've met me now. I'm here. If there is something in the future I can help you with. So it is a tough balance, I think, sometimes of um not pathologizing normal kind of emotional expression. Um, but also wanting to make sure people are getting the support that they need. And I think a collaborative approach even is helpful. That like, hey, as we're meeting today or as we've been meeting, like I've noticed this keeps coming up, right? When that happens with my patients, I always want to make sure that they're, getting the support that they need. That's not my area of expertise. Have you met with someone? Do you think that could be helpful for you? I've got some referrals if you'd like. So not like a you need to do this or something's wrong with you, or but like that collaborative, shared decision making kind of approach of here's what I'm noticing. What do you think about it? And here's some things that I could offer if you're not already connected with someone. And sometimes they're not interested, they turn it down, but you're planting seeds there too if that is something in the future that could be helpful for them. Yeah. Long, twisted, not a clear. here's your 3 steps to doing it kind of thing. But
That might have been the most perfect answer I've ever heard for this
okay.
particular very sticky question. And I just really love this person-centered approach. In fact, I am redubbing patient-centered approach that we've been talking about this whole time to person-centered because it really hones in on the issue, right? Don't instead of seeing this person simply as a patient, also see the person in front of you. How would you talk to a friend? You know,
Yeah,
um, it,
yeah.
and each one of us have had these moments of mental instability, where and that even that feels like a false description. It's just life. Each one of us have
Mhm,
had
mhm,
ups and downs in life. And sometimes just having someone who is able to be genuine, to be empathetic, and to respect us is, as you said, necessary and sufficient for whatever it is that we're going through. And it brings me back to a point you made earlier about how, research shows that really the success of the therapy is predicted by how good that interpersonal relationship is between the therapist and the patient. And did you know that the research this is the same for manual therapy?
that doesn't shock me, but I
It's
did
not
not
even
know that.
about talk therapy. It's also about
Wow.
it is more predictive of a successful outcome. The relationship between a manual therapist and the patient is more predictive of a successful outcome than that person's training in their field.
Mm, hmm, hmm.
Um,
Wow.
so yeah, even in just what we consider the body arts,
Mm.
that the relationship is first and foremost of importance. I love your reminders not to pathologize and to treat this conversation as a collaborative one, asking them what they want, putting, volleying that ball a little back in their corner, giving them agency. Really, really wonderful answer. I knew we were going to have a wonderful conversation, but this really blew it out of the water. I'm so grateful to have had this time with you. Is there anything else that you want to share or talk about as a clinical psychologist
Oh,
in the narrative
don't open up
space?
to anything I want to talk about. Let's see. Although that does make me think of, we listen to people's stories all day. We do need outlets to
Mhm.
share our own stories in appropriate ways. That's another way. It's not a bias necessarily, but bringing our bringing our stuff into the room in terms of putting it on the patient to, even if we're not trying to get them to help us, right? Needing to be cautious there. I will say that Carl Rogers initially called his approach client-centered or patient-centered, and then he switched it to person-centered. So he went through that process you were just describing too, of like, well, hold on. Um, how
Yeah.
do we want to approach this and talk about this? So, um, yeah, it's wild that human connection, even in you might just, with all this talk of AI and stuff, and a whole complex topic I won't claim to be able to, right, et cetera. But I just pictured as you were talking about kind of the manual therapies, like if we had robots that could do that and knew the right points and could, do the right techniques and stuff, would it be the same? And yeah, without that connection, would there be some benefit? Probably. Sure, there is something to the techniques that we use in our various fields, but does it help the patient fully get where they could go? And so that goodness of fit, I think, also then behooves us to really be aware of our ego, to be humble, and to be open to, much as we might not like it to be true, that we cannot be everything for everyone, and we are not going to be the best fit or even a good fit for all 8+ billion people on this planet that we might encounter. And that's okay. That doesn't mean you're bad at your job. That doesn't mean, if you're not connecting with anyone, I'd say, okay, we need to look at that. Um, um, but it's okay if they need to seek someone out or they're getting a second opinion or they are trying 3 different therapists first to see who do I connect with best, right? How can we help support patients get where they need to connect so that they can get the best help that they can get, even if that's not with us?
Well, I can tell your patients, your people, are very, very lucky to have you.
Well,
Thank
thanks.
you so much for spending this time with me today. And thank you to everybody who's listening. Thank you for joining us on the Bridge podcast, where medicine meets the arts. That's my cool new tagline. Um, Join us next week. We're going to be talking about metaphors and symbols and how they help communicate meaning in pain experiences or healthcare in general. I look forward to seeing you all then. Thank you again, Justin.
Yeah.